Um, Hello,
You can start now.
Right, sir.
Dr. Anusha. I'll introduce you and then you take over.
Yeah,
Hi,
sure.
Dr. Nilanjan. This is Dr. Srinidhi. I work as a molecular hematologist in Dr. Bhargav's team, and he right now can't join. He's busy in a meeting.
I think we are live, Srinidhi. Let's start off.
Okay. Hello, one and all. Good evening, and welcome to another series of innovations in hematology. And today we are very privileged to have somebody like Dr. Nilanjan, who's going to be talking to us about CAR T cell and bispecific antibodies. Dr. Anusha is the brainchild behind him, and she's going to be moderating the sessions. Over to you, Dr. Anusha.
Okay. Um, Very good evening to one and all. This is our team at Fortis Hematology. We care for adults and children with blood cancers here at Gurgaon. It gives me great pleasure to invite you all to today's session on mantle cell lymphoma. I think my slides are not moving, Mayank.
Yes, your slides are not.
Can you please share the slides from your side, please?
Yeah. Jignesh ji.
Just try to share the again, and you can see there is a little arrow in there. Just try to click it.
Okay, yeah, it's all good. So jumping right into the session, I think mantle cell lymphoma in many ways is a disease that doesn't fit into any neat categories. The clinical spectrum of mantle cell lymphoma is so wide, and the spectrum of how we choose to treat it is even wider. On one end, we have intensive chemotherapies, and then on the other end, we have the appeal of an entirely chemo-free regimen. And this contrast is even more highlighted in a setting like ours, where we do have patients who still struggle with access to continuing basic medicines like BTK inhibitors, leave alone CAR T cell therapies and bispecifics. But on the other hand, we are very excited for our growing body of patients who have access to molecular testing, who can procure BTK inhibitors for a prolonged period of time, who can have access to our homegrown CAR Ts. At least we have two products that I mentioned earlier, and can procure bispecifics if the need arises. So this adds an additional layer of responsibility where we are trying to tread the path between both of these extremes and individualize the approach for each patient in front of us. And whatever approach we start with, if it's not curative, especially in a disease like mantle cell lymphoma, the question comes, what next? And the answer to that is not that simple. And to help us answer these questions and guide us, we have an expert among us to deliver today's lecture. It gives me great pleasure to invite Dr. Ghosh. Dr. Nilanjan Ghosh is a professor of medicine and chair of Department of Hematology Oncology at Atrium Health Levine Cancer Institute. Dr. Ghosh is a lymphoma researcher and a leading international expert in lymphoma with deep expertise in mantle cell and other B-cell malignancies. He has led and contributed to numerous clinical trials in lymphoma, has an extensive body of peer-reviewed work, which is helping shape modern lymphoma strategies. It's a privilege to have you here, sir. Over to you.
Thank you so much. Truly appreciate the invitation. And let me see if I can share the screen here. If you can stop sharing on your end. Let's see. Are you able to see my screen now?
Visible.
Yes, sir.
All right. So today we'll be spending the next hour and a half or so, not all just presentation, but happy to take questions, mainly towards how there's been a paradigm shift in mantle cell lymphoma from a very chemotherapy-based treatment regimen with, high dose chemotherapy being center of it, after chemoimmunotherapy in frontline setting, to targeted agents, whether it's BTK inhibitors, venetoclax, or CAR T cell therapy, bispecific antibodies, and so forth. So, mantle cell lymphoma is there is no one good standard for the treatment in mantle cell lymphoma. So there is a lot of art and science mix when you are seeing the patient. So hopefully we'll be able to come to some sort of understanding of how complex the treatment landscape is, but how much we have improved in terms of outcomes and treatment options over the last decade or so. So there's certainly been a paradigm shift in the treatment of mantle cell lymphoma. Let me see if I can just move this bar out. Okay, so you can see that BTK inhibitors, CAR T cell therapy, immunomodulatory drugs, proteasome inhibitors, BCL2 inhibitors, bispecific antibodies have all made inroads in mantle cell lymphoma. At least in the US, BCL2 inhibitor and bispecific antibodies are not FDA approved for mantle cell lymphoma, but they are on the guidelines, so they can be used with insurance approvals, but they have not officially been approved by the FDA. So next slide. Let's see. To see. Okay, there you go. So we'll talk about, in this talk today, we'll talk about BTK inhibitors, CAR T cell therapy, and bispecific antibodies. I'll talk a little bit of venetoclax in combination with BTK inhibitors, but our focus is going to be on these. We'll not be able to spend time on lenalidomide-based regimens and bortezomib. So let's start with BTK inhibitors. There are two types: covalent binding BTK inhibitors and non-covalent binding. So the first one which came through was ibrutinib, now over a decade ago, and then acalabrutinib and zanubrutinib more recently, and then non-covalent binding BTK inhibitors, which are primarily used after failure of covalent binding BTK inhibitors, and pirtobrutinib is the drug which is approved for that. So let's start a little bit with our sorry. So let's start a little bit with the first treatment study which I'd like to discuss, and that is the SHINE study. So we know that I'm not covering chemotherapy because I'm sure that has been in place for a long time, whether it's bendamustine rituximab or whether it is high-dose cytarabine-based regimens, R-CHOP alternating with DHAP or high-dose Ara-C. Those have been the backbone. What has happened in the last many years is addition of BTK inhibitors with the chemoimmunotherapy backbone. So the first one which came through was the SHINE study, which is a randomized clinical trial with bendamustine rituximab as the backbone, and patients were randomized to either bendamustine rituximab placebo or bendamustine rituximab ibrutinib, and they all got rituximab maintenance, which has become a very standard thing in mantle cell lymphoma. And so you can see fairly large study with this primary endpoint in the study was PFS. So the primary endpoint was met. You can see the blue line is above the green line, and you can see that the PFS, median PFS, was 80.6 months with ibrutinib plus bendamustine rituximab, compared to 53 months with placebo and bendamustine rituximab. So giving continuous ibrutinib after standard BR induction led to a longer progression-free survival compared to just bendamustine rituximab followed by rituximab maintenance. There was a 24% reduction in risk of progression, progressive disease or death when this combination was used. So the next thing I wanted to show you, though, is that by doing the strategy, are we improving overall survival? And the answer is no. There is no improvement of overall survival when you're combining BTK inhibitor like ibrutinib with BR. And you can see the overlapping curves between the two arms. And when you look in the right on the table, you can see that yes, there was more deaths because of progressive disease in the placebo BR 54 compared to 30 in ibrutinib plus BR. But there were more deaths due to treatment-related adverse events in ibrutinib BR compared to placebo BR, and so that nullified out. Now, agreed that this was done in the pandemic era, so there were deaths from COVID, but there can be other deaths from long-term toxicity from BTK inhibitors such as ibrutinib. So, then I'll talk a little bit about sequencing, but let's just go through to the other studies which I'm going to discuss in the frontline setting before we go to relapse refractory. So, another very important study, the ENRICH study, which was done in the UK, and this was a study with a different design. There was a choice of what to use in frontline chemoimmunotherapy, whether it's RCHOP or BR. Not sure why they use RCHOP, because I think we've known for a while that out of all the lymphomas, RCHOP is not the chemotherapy of choice in mantle cell lymphoma. If you want to use RCHOP, it should be with something else, like perhaps with cytarabine, high-dose cytarabine, alternating with RCHOP or DHAP. But RCHOP by itself is not really a good chemotherapy backbone for this disease. BR is better, and many studies have demonstrated that. But in this study, there was a choice left to the investigator to use either RCHOP or BR in the standard arm and ibrutinib rituximab in the investigational arm. And the maintenance was, again, if they got R chemo, they could get rituximab maintenance, and if they got ibrutinib rituximab, they could get rituximab maintenance, but on top of that, they would get ibrutinib ongoing till progression. So one arm finished early and had fixed duration, the other arm was ongoing treatment. And so primary endpoint, again, PFS. So what you see over here is that overall, if you look at that box below, overall PFS was better in ibrutinib plus rituximab compared to R chemo, 65 months compared to 42 months. And that was statistically significant. However, when you look at BR and RCHOP individually, those patients who got BR, it was similar outcome to our ibrutinib. So you have 6 cycles of chemotherapy followed by rituximab maintenance, BR giving you same outcome as continuous long-term ibrutinib. But of course, RCHOP, when you compare it with RCHOP, ibrutinib plus rituximab was much superior to RCHOP. We have always known RCHOP is an inferior chemotherapy for mantle cell lymphoma when used by itself. Whether it's compared to VR-CAP, which is better, whether it's been compared to BR, that's been better. But in this case, those investigators who chose to use RCHOP still got an inferior outcome for the patient compared to rituximab plus ibrutinib, and that was statistically significant. Here you have the PFS for subgroups. So when you look, though, in the blastoid disease, which is a very aggressive form of mantle cell lymphoma with cells, larger looking cells, and also high Ki67 often. You can see in this case, though, our chemo did better in these fast growing mantle cell lymphomas, and ibrutinib plus rituximab was not as good. Clearly, it was much more superior with our chemo. So not all patients benefited from ibrutinib rituximab. These blastoid patients did not. And you can see the hazard ratio is very significant. For mutated P53, though, you can see how much ibrutinib rituximab was better than our chemo. And that is also very important to note, although the numbers were small. So you can see the confidence interval in the hazard ratio did cross over, and this was not statistically significant, but still numerically significantly improved. When you look at overall survival, again, you see really no difference in terms of the intention to treat population. That's, I think, something important to remember as we start thinking about incorporating BTK inhibitors in frontline therapy. Okay. And then in terms of side effects, as expected with ibrutinib, there were higher cardiac side effects. You see 22.4% with BR. You're not going to see much of that. With RCHOP, a little bit because of the anthracycline. somewhere in the middle. But you'll see obviously bleeding side effects were seen in ibrutinib, and for some reason in R-CHOP there were some bleeding side effects as well, but not so much in BR. Clearly atrial fibrillation stands out with 6% in ibrutinib rituximab, which is actually much lower than what we have seen in CLL studies, where the incidence has been up to 15-16%. And some of the other cytopenias and coronavirus infection, obviously we know that even with bendamustine, you're going to start seeing, COVID and other things because of lymphodepletion. So what are the authors' conclusions for ENRICH? It was the first randomized trial to demonstrate improvement in PFS for a BTK inhibitor combined with rituximab compared to R-chemo, but this was limited to the R-CHOP group, and BR outcomes were very similar. Ibrutinib may have a particular benefit for those low proliferating mantle cell lymphomas like the Ki-67 less than 30%, and the safety profile was consistent with the known AE profile of ibrutinib. So, and then I want to talk about the triangle study, which I know that you have certainly are aware of, which has been recently presented and also published by Dr. Drehling from Germany. This is a European study. It had the eligibility criteria was a younger population. So when we start thinking about mantle cell lymphoma chemoimmunotherapy backbones, we think older population BR, traditionally non-transplant eligible, younger population anthracycline based plus high-dose Ara-C based, and then transplant. So we are thinking more of the Nordic regimens or the French regimens, and so here the LYSA regimen. So here the backbone, which is arm A, the standard arm, R-CHOP alternating with R-CHOP and then RDHAP. Followed by autologous transplant and observation. So no BTK inhibitor in that arm. Second arm, A plus I. So here there was same treatment, but ibrutinib added with 2 years of ibrutinib maintenance. And then the third arm is the bolder arm with no transplant, ibrutinib added, and 2 years of ibrutinib maintenance. Rituximab maintenance was added to all 3 arms, but not every patient got rituximab maintenance. About 50% or so, 50 to 60% of patients got rituximab maintenance. The primary endpoint is failure-free survival. A little bit different from PFS. You can consider failure-free survival to be more like a modified PFS. So what is new in failure-free survival is somebody achieves stable disease, that's an event. In progression-free survival, if somebody achieves a stable disease, until they progress, it would not be considered as an event. But here it's a little bit stricter. So if you did not receive a CR or PR, then it's an event. So failure-free survival was the primary event over here. You can see the characteristics. I won't go much, but they were well balanced between the arms, especially MIPI score, which is the Mantle Cell International Prognostic Index. Was well balanced between the arms. So you can see over here, it's a little bit complicated because there's a 3-arm study and it's not all designed to compare every arm with each other. But the big take-home points, failure-free survival was much better. You can see with the green, which is A plus I, so autologous transplant plus ibrutinib, compared to autologous transplant alone. So when you add ibrutinib, and if you are going to do a transplant, then it is going to be better if ibrutinib is added versus ibrutinib not added. So you can see failure-free survival, 82% versus 70%. And here we are talking about time-limited ibrutinib. This is not indefinite treatment, unlike the previous study with SHINE, or the study which I'll show you after some time, the ECHO study with bendamustine rituximab. So even with fixed duration ibrutinib, when added to transplant, A plus I was better. Median not reached in both, but you can see that significant improvement in failure-free survival with a statistically significant hazard ratio. When you now look at A versus I, so standard arm of transplant and R-CHOP RDHAP with no ibrutinib versus no transplant, but R-CHOP RDHAP plus ibrutinib. So even when you don't do transplant, but just add ibrutinib, you can see that failure-free survival superior with ibrutinib, significant p-value over there. So this was the first time we realized that the transplant, autologous transplant, high-dose chemotherapy followed by stem cell rescue may not be necessary if you add a BTK inhibitor to frontline therapy, even if it's a fixed duration BTK inhibitors, which is, I think, an important thing to lower long-term toxicity and lower costs. And then what happens if you look at A plus I versus I? So here you saw that if autologous transplant was done and ibrutinib was given versus no autologous transplant done and ibrutinib given, autologous transplant really didn't add anything. So again, another demonstration that autologous transplant may not be necessary in most patients with mantle cell lymphoma if BTK inhibitor is added. So just some subgroup analysis, but you can see all the boxes are just a little bit either on the center or to the left, but error bars are crossing. So really nothing, no particular subgroup stands out. In terms of overall survival, maybe a little too early, but what you see is here you are seeing A versus A plus I versus I, and 81% versus 88% versus 90%. A versus I, so autologous transplant versus ibrutinib, hazard ratio is significant. So if you add ibrutinib, longer overall survival. A versus A plus I, again, significant. So autologous transplant given in both arms, but I added to one arm. So the ones who got I plus autologous transplant, ibrutinib, improved overall survival. And A plus I versus I is ongoing. I think it'll be published soon. So I shouldn't talk about that. So what are the conclusions from the author? A plus I, so autologous transplant plus ibrutinib, superior to autologous transplant alone for failure-free survival and overall survival. Autologous transplant is not superior to ibrutinib, and A plus I is not superior to I. So at the end of the day, I think this demonstrates a diminishing role for autologous transplant if you use BTK inhibitor upfront with this more intense chemotherapy regimen. Better safety profile with ibrutinib alone than autologous transplant plus ibrutinib, but that's obviously a common sense. If you don't give high dose therapy, you're not going to get mucositis, cytopenia, infections, all those things which can come, and sometimes perhaps treatment related myeloid neoplasms down the road. And A plus I may be better option for first line treatment of younger patients with mantle cell lymphoma. And so those are the main things of the triangle study. Okay. I'm going to just quickly pause for a second because I'm seeing something with the slides and I just want to make sure it's the updated one. Hold on one second. Sorry for the inconvenience.
Dr. Ghosh, are you still with us? Dr. Ghosh, are you still with us?
Just give me a second. I updated the presentation, but I think I emailed myself the wrong presentation. So I'm trying to access the
No
the
worries.
presentation.
No worries.
Give me a few minutes.
Ma'am, you are in mute.
For those of us sending in queries, if the meeting is still on, yes, the speaker has just taken a short pause to rearrange his slides. Give us a few minutes, it will be back on. While we are restarting, if the audiences have any queries, you can start putting it in the chat box. Thank you.
Sorry, we'll restart. I had updated the presentation yesterday at work, but I'm not able to access that one. So I was just trying to see if I could access that because I finished 2/3 of the presentation earlier, but then there was bispecifics and other CAR T stuff which I'd added. So unfortunately, I'm not able to access that. So I'll just go with what I have and then take questions.
No worries.
So let's see. From current slide, we'll go back. We talked about, so we'll now move on to ECHO. So I guess the next part will be the ECHO study. Sorry about the break. I spent quite a bit of time yesterday to update and about bispecifics and other CAR T stuff, but unfortunately, that's not in this presentation. But I'll be happy to answer questions on those. And I can share the slides with you guys so you can take a look after the presentation.
Sure, sir.
So let's talk about the ECHO study. This is a very important study because it led to approval of acalabrutinib in frontline mantle cell lymphoma. And so in this ECHO study, the backbone was bendamustine rituximab, followed by maintenance rituximab, and acalabrutinib was given until progression or toxicity, so continuous acalabrutinib, versus bendamustine rituximab followed by maintenance rituximab. And those patients who had progressive disease, they could cross over to get acalabrutinib. Primary endpoint here is PFS, and overall survival is also seen, but with a crossover design, overall survival can be impacted. But I think it gives us important answers about this. So the trial did meet its primary endpoint. What you can see clearly is patients who got acalabrutinib BR did better than placebo BR, so PFS was improved, and overall survival, including when you look at crossover, patients were able to cross over, so there was no difference in overall survival. So I think even if the trial did not have a crossover built in, patients could have got standard of care acalabrutinib and perhaps would have not shown overall survival advantage. But clearly there is PFS advantage, and this was where the trial was designed for. So in this, what you can see, PFS in high-risk population, acalabrutinib plus BR was better than placebo plus BR, even in high-risk patients. And in patients with high Ki67 over 30%, pleomorphic histology, and with P53 mutation, there's also significant improvement in PFS with acalabrutinib plus BR versus placebo BR. So, moving on to another chemotherapy regimen here, many investigators here do BR, but they add cytarabine with the BR, even in younger patients. So this is another chemo backbone, which is used, BRCR, so that's bendamustine rituximab and cytarabine rituximab, 3 cycles of each, and using that arm, acalabrutinib added to one of the arms, BRCRA, and then there is an arm with BRA, so just ABR, similar to the ECHO study. So 3-arm study was presented at ASH, not in 25, but in 24, by a colleague of mine, Dr. Wagner Johnston. And what you'll see over here is that the endpoint here is PET CTCR, and they also looked at undetectable MRD. So I think that is very important because MRD is becoming an important endpoint in mantle cell lymphoma. And then there were some secondary endpoints which longer follow-up will be better for that. But at least when you have a PET CR as your endpoint, you can have a quick readout of a study. And so what you see over here is, the PET CR rate for all 3 are pretty similar. So 82% to 78%. They did some sensitivity analysis, again, very similar. And so, I think it's important to note that, similarity in outcomes. Remember, in one of the arms, especially the BRA, there was no cytarabine added. And despite not having cytarabine, when acalabrutinib was added, if you just look at BR-CR, that's the chemotherapy, versus BR with no cytarabine and just replaced with acalabrutinib, the outcomes are very similar. So I think patients would also perhaps prefer to have a BTK inhibitor than 3 doses of high-dose cytarabine with all the side effects it can bring. The PFS, 12-month PFS, was very similar in all three arms. If you go down to the lowest row, 90, 91%, and 92%. So I think another important study demonstrating, similarity in outcomes, even when high-dose treatments like high-dose cytarabine is removed. If you look at the undetectable MRD group, the PFS really, appears to be better than those who were MRD positive. I think that makes sense. But if patients, this achieving an undetectable MRD is a very important endpoint in this disease, and I think that is demonstrated over here. Side effects, I won't go through too much in detail. The expected side effects of high-dose cytarabine, you can see those in the cytarabine arm. And when you look at BRA, all of a sudden you don't see much platelet count decreased and things like that. You also don't see in terms of some of the other toxicities, like the degree of neutropenia is not going to be right. You have 40 to 45% grade 4 neutropenia in the cytarabine containing arms, but in the BRA arm there was less. Interestingly, in this study, the BRA arm was stopped early, but despite that, I think the main and punchline I feel from this study was the least toxic regimen which was BRA, had similar efficacy, and therefore it's an option to avoid high-dose cytarabine in patients with mantle cell lymphoma if you use BRA. Now moving on to a few studies which are more chemotherapy free. So if you look at this TRAVERSE study, which includes acalabrutinib in frontline mantle cell lymphoma, these are patients who get acalabrutinib. I mentioned initially that I won't talk separately much about venetoclax, but there'll be some discussion about combinations with BTK inhibitors. So this is one regimen. It's acalabrutinib, 100 milligrams PID, which is standard dose, venetoclax with the ramp up, starting in cycle 2. So after a little bit of debulking from acalabrutinib and rituximab, and then basically, patients, if their MRD is tested, if MRD negative, then acalabrutinib is continued till progressive disease from cycle 15 and onward, because venetoclax stopped at that point, versus observation. If there is MRD positive CR or PR or stable disease, then acalabrutinib is continued till progression. So early results from this study, but like MRD negativity is looked at over here, which is, you can see in the evaluable population, very high MRD negativity of 93%, overall response rate 100%. In the evaluable population, and CR rate is high at 94%. So you can see a completely chemo-free regimen giving pretty high response rates. The overall survival is pretty good at 1 year, but that's expected if the CR rate is going to be that high. But I think this is the regimen which is actually making a lot of waves across many institutions here in the US, and that's the Bowen study, recently updated at ASH by Anita Kumar from Memorial Sloan Kettering. And this is a very really, again, another novel regimen. But what is unique about this study, which no one has done before, is that it only included patients with P53 mutations. So we don't know often what to do with them. Historically, we know patients with p53 mutations in mantle cell lymphoma don't do well with chemoimmunotherapy. They don't do well with autologous transplants. So a lot of effort is wasted in giving these high-dose therapies, and yet the outcomes are not good. And in this study, it's Bowen study. So B is Brukinsa, which is zanubrutinib. O is obinutuzumab, and venetoclax. So that's why the name Bowen. Here you can see that you have zanubrutinib, then you have obinutuzumab given at these various intervals, and it stops at cycle 8. And venetoclax is started a little late because you want to debulk so that don't go through all that tumor lysis mess with venetoclax, but then again fixed duration with that. So with this regimen, they also studied undetectable MRD. And if there was CR and undetectable MRD, then stop treatment. So again, a fixed duration regimen for those patients. If it's less than CR or detectable MRD, then continue Zanu and venetoclax. So efficacy was recently updated. ASH, there's a blood paper which is with 25 patients, but at ASH this was recently updated, and the efficacy here is with 50 patients, overall response rate is 98%. So again, chemo-free regimen giving 98% overall response rate, 94% CR. This is in only p53 mutated. So one can only imagine what this would be if regular risk patients were taken. MRD negativity at end of treatment, 93%, and 2-year PFS, 86%. So I think these are phenomenal results. It's not a randomized study. It's a smaller study, but it's hard to get so many frontline p53 mutated patients. And the side effect profile is listed over here. There are side effects, obviously, with BTK inhibitors combined with venetoclax. But this is, second generation BTK inhibitor combined with venetoclax. And, I think the side effect profile is still much better than using chemotherapy, especially high-dose Ara-C. So I wanted to get to a central question when we are talking about frontline introduction of BTK inhibitors. And then also availability of BTK inhibitors in the relapse refractory setting. So the central question is, does adding BTK inhibitors upfront to BR improve outcomes enough to justify adding the toxicity and cost? The key trials we talked about was SHINE, which is ibrutinib included, ECHO, which is acalabrutinib included. And the PFS argument is what the trial showed, right? So the PFS, it is better. We can see the results here, just summarize. But what about overall survival, right? So neither SHINE nor ECHO demonstrated overall survival benefit. SHINE had a hazard ratio of 1, ECHO hazard ratio of 0.9, numerically worse overall survival in SHINE. Why no overall survival benefit despite PFS improvement? That is because sequential BTKI works at relapse. So in relapse setting, if you use acalabrutinib, you can see overall response rate and CR rate 82%, 48%, with a median PFS of 22 months. Zanubrutinib, 84%, 78%, with a PFS of 33 months. So if that's the case, then, just look at the numbers. So if you do first-line BR followed by acalabrutinib, ECHO, then not ECHO, but like sequential approach, you're going to have 50 months with BR and 22 months with acalabrutinib, so about 72 months. First-line BR followed by zanubrutinib in recurrence, 50 months plus 33 months, so you have 83 months. But ECHO showed acalabrutinib plus BR was 66 months. So you're really not getting much benefit now, but think of the treatment exposure. For those 66 months, the patient was on acalabrutinib, but you can get the same effect or perhaps even better by just 22 months on acalabrutinib. I'm simplifying it. Not everybody is going to be, I'm just talking about medians, but you get the idea that sequential use is also, very much valid with lesser exposure to the patient. So these are the NCCN guidelines in first-line therapy. And you can see over here that, it includes obviously everything, chemo, chemo only, and sequential, like chemo plus BTK inhibitors like triangle is included, but Nordic regimen, BR, those are also included in this. So it's not essential that every patient has to get BTK inhibitor in the frontline setting. However, if you come to the rightmost part of it, for classical P53 mutated disease, and this comes back to a very important discussion which I have with our hematopathologist, that P53 should be checked for every patient with mantle cell lymphoma in the frontline setting, because there's no point in exposing these patients to high-dose chemotherapy and cytarabine or other based regimens and get inferior results when you have regimens like Boven out there, which can give you much better results in a chemo-free and oral treatment, except the obinutuzumab, which is the IV treatment. So you can see that for classical P53 mutated, the guidelines suggest suitable for all patients is ven, zanubrutinib plus obinutuzumab, which is the Boven regimen. And then, others are also included. But in this case, they are not talking about a BTK free. They are pretty much BTKI included in frontline setting for this thing. And the Traverse regimen, which I presented, is also included here, but not for aggressive patients with aggressive induction. So I think who would benefit from concurrent BTKI is a combination in first-line mantle cell lymphoma, young patients with mantle cell lymphoma with aggressive blastoid pleomorphic morphology, where you are thinking of using an R-CHOP-based, which means R-CHOP with high-dose cytarabine or platinum included. There, the triangle regimen, where BTKI is incorporated, and then the other one would be patients with P53 mutation, where you're using obinutuzumab, zanubrutinib plus venetoclax. For the triangle regimen, I think it's important to understand that it's time-limited BTK inhibitor. It is not indefinite. So again, that is very helpful for our patients. So, the toxicity argument is both toxicity in terms of symptoms, but also financial toxicities. BTK inhibitors in the US are extremely expensive, over $150,000 per year. So that is deferred if you do sequential, even though insurance covers, but there's a lot of co-pays and things like that. Duration of BTKI in a concurrent is continuous from diagnosis, but in sequential only for the time between the time when they relapse to however time they get benefit. And then AE management, if somebody is exposed to BTK inhibitors for 7-8 years, there's more risk of cardiac toxicities and bleeding and other BTK-related toxicities. But if you use it for a shorter time, it's lower. So I think it also provides patients treatment-free interval for a long time before needing BTKI. So just to drive home the point, concurrent BTKI means daily oral medication indefinitely, at least for many years, perhaps, frequent monitoring requirements, drug-drug interaction management. Many BTK inhibitors will overlap, will have drug interactions with other drugs, and dietary restrictions. And also, we know that BTK inhibitors need to be held before procedures, and some patients forget. The doctors will ask you taking aspirin, but they won't ask about the BTK inhibitor, and then there'll be bleeding complications, and then treatment-free intervals are positive. No overall survival benefit by using concurrent BTK inhibitors, at least with the BR regimens, and they remain effective at the time of relapse. Reduction in financial toxicities and quality of life is ensured. So here are the summary of what you can get with BTK inhibitors in relapsed refractory mantle cell lymphoma when used sequentially. I didn't talk much about ibrutinib because, at least in the US, ibrutinib has been withdrawn from the market for mantle cell lymphoma. And, only acalabrutinib and zanubrutinib are used. But you can see, of course, acalabrutinib and zanubrutinib also have better outcomes than ibrutinib. And zanubrutinib median duration of response is not even reached, but median PFS with zanubrutinib is 33 months after failure of frontline therapy. And all these are better if you use it in second line compared to third line. So you can see that over here, if you use one prior line of therapy for BTK inhibitors, you can see the red curve on the left figure is much better than the blue curve when BTK inhibitors are used much late in treatment. And patients who have late relapse do benefit significantly from BTK inhibitors compared to chemoimmunotherapy. So in relapse setting, using BTK inhibitor can be much better than trying chemo again. So that's what is shown in the study on the right. I'll briefly mention, I know we are probably out of time, so maybe it's a good thing that I didn't have the slides. It's kind of hard to cover CAR T and bispecific antibodies plus BTK inhibitors all in one talk. So the Simpatico study, which we participated in, I'm an investigator on this study, is ibrutinib venetoclax compared to ibrutinib placebo for relapsed refractory mantle cell lymphoma, but there's also a p53 mutated frontline group which was treated in the study, that the study has a PFS endpoint, and you can see that PFS was much better with ibrutinib venetoclax compared to ibrutinib alone, and this was presented at ASH and then updated at ASCO. And so we do know that there is an unmet need after covalent BTKI therapy. So, overall survival from date of discontinuation of BTKI therapy, you can see that, for patients, the survival keeps going down after failure of covalent BTKI therapy. If patients do receive treatment, they do better than those who are not able to get any treatment post BTKI therapy. And I'll skip the discussion on the right. So what are the options for post-BTKI therapy? Covalent, non-covalent BTKI pirtobrutinib is an option. That's a more continuous treatment option. So that's depicted by this AI-generated image that patients will be on pirtobrutinib for as long as they get benefit, or you can have a fixed duration therapy or one-time treatment with CAR T-cell therapy, and the two products which are used are Brexucell or Brexucaptogene autoleucel and Lysocaptogene maraleucel. And so those are the treatment options for these two diseases. I think since I'm significantly over time, I don't know if I should stop here or talk a little bit about pirtobrutinib before stopping. Anusha, please let me know what.
You can go ahead, sir. You can go ahead and complete.
Okay, so I'll probably go ahead a little bit because I don't know, is pirtobrutinib available, easily
No.
for your site? I'm sorry?
Not right now, sir. Not to us.
Okay. But it may be in the future. So again, a very, very well-tolerated BTK inhibitor. And what you want to see over here is those patients who failed ibrutinib or acalabrutinib or zanubrutinib. We are looking at only outcomes in those patients with pirtobrutinib. And you can see that these patients do respond. There's a duration of response. Median duration of response is about 1.5 years with pirtobrutinib. Now, if you use it for BTK naive patients, it's really high. But this is patients who have failed already a BTK inhibitor. So even in those patients, 18 months duration of response, and a PFS is not that great, but of course, some people don't respond. So that's PFS, 7.4 months, overall survival about 2 years. But in the BTK naive cohort, which I've noted in the box below, the duration of response, 18 months, everybody was in a response, which is pretty amazing. And 93%, 92% PFS and overall survival extremely high. The other advantage with pirtobrutinib is that it is very, very safe. The side effect profile with pirtobrutinib is probably the best amongst all the BTKIs. But because it's non-covalent, it's being tested primarily after failure of covalent BTKI and this thing. And you can see majority of patients respond, again, showing there's not that much CR. We know that with single agent BTKI, CR rates are not that high. But again, patients do respond even in patients who have prior BTKI. And those patients who are BTKI naive, the numbers are very small in the population, but those have very good responses. Side effect profile is really good. You can see grade 3 or 4, very low. right? Less than 5% incidence of any grade 3-4 AIs. Atrial fibrillation rate is extremely low at 3.6%. So very, very safe BTK. I hope you have access to this drug sometime in the future. I probably can just maybe talk about one CAR-T study very briefly, and we can probably, just discuss the role of CAR-T. So I'll say that in mantle cell lymphoma in general, CAR-T has been transformative for those who can get CAR-T. You may think that, we have access to CAR-T in the US and lots of patients are able to get CAR-T, but unfortunately, the data shows that only 2 out of 10 patients who are eligible for CAR-T, even in the United States, are getting CAR-T. So if 10 patients are eligible for CAR-T, only 2 get it. That's because of access. Mainly because of access, and CAR-T centers, there are many, but not all patients are able to come to those centers, and many patients are treated in the community where CAR-T is not available. But for those who can get it, it has been transformational. And Brexucel, was the first CAR-T product which was approved for mantle cell lymphoma, I think anywhere in the world. And this is a very important study which demonstrated this is standard CAR-T, right? So patients who have failed at least 1 to 5 prior therapies, and this included an anthracycline or bendamustine based therapy. They all were BTK exposed, so they had failed that. And I just shown you that the outcomes with patients who fail BTK therapy are very poor. So these patients went through CAR T cell therapy. So what is CAR T cell therapy? I'm sure you have 2 products available. So I'm sure you're doing it frequently, but it includes lymphodepletion. But before that, patients are leukapheresis. White cells are collected. These cells are then genetically modified. The T cells are genetically modified to insert the CAR gene for expressing CD19. So now the T cells are educated and they have a CAR on their surface, so chimeric antigen receptor to CD19. And of course, we know B cells have CD19. So this goes and latches on to all the B cells, so B cell lymphoma, and then kills them. So in this study, bridging therapy was only allowed with dexamethasone or ibrutinib or acalabrutinib, but not with chemo. And then lymphodepleting therapy with fludarabine and cyclophosphamide, which is very standard, was used. And then patients received their Brexucel product. So 68 patients treated. Very, very difficult patient population because median prior numbers of therapy were 3. 100% of them had received BTKI, and 62% were refractory to BTKI. So this was a patient population where the expected overall survival would be very, very low. And 43% had also received transplant. High Ki67 in 82%, and blastoid morphology and p53 mutation included. So these patients, you're seeing now, a median PFS of over 2 years, which is pretty amazing, and also a median duration of response of 3 years. So for those who responded, the median duration was 3 years. And overall survival is close to 4 years with this. So really transformational, because we would have not expected this with any other existing therapy, not even bispecific antibodies. The side effect profile is pretty strong. CRS 91%, neurologic toxicity in 63%. And you can see that grade 2 and 3 CRS, so about over 50% have grade 2 and 3 CRS. So a lot of tocilizumab use, and also you're starting to see 22% grade 3 ICANS, which is immune cell effector associated neurotoxicity. So Brexucel, even though it has high efficacy, unless it's a seasoned CAR T center where very well very good with management of CRS and ICANS, it can be very difficult on patients. So the newer product Lysosal has much lower CRS and ICANS, but also pretty good efficacy, and that's been more in favor in recent times. But because of this high CRS, the trial, the ZUMA-2 trial, which studied the Brexucel in relapsed refractory, introduced a few changes. One was in the initial cohort, there was no corticosteroids initially. They thought if you give steroids, they'll kill T cells. And if you kill T cells, the whole purpose is lost. But no, not really. So you can see that in later cohorts, which is in the blue, sorry, in the early intervention group, which is in the green, tocilizumab was allowed in grade 1 CRS, and corticosteroids were also allowed early on. So for neurologic management, for neurologic toxicities, and with introduction of tocilizumab early and corticosteroids early, you started seeing a little bit better in terms of toxicity profile. You see the green is always a little bit lower than the blue in the curves, and that's green is the early intervention group where you're early intervening with tocilizumab and steroids, and blue is the one which is late intervention group, and so it was better toxicity profile with these interventions. So with this, you can see that the overall response rate is exceedingly high, over 90%, with 2/3 of patients achieving a CR, and really excellent efficacy. So I'll end over there. I'm sorry, we are missing lysocell and bispecific antibodies, but I can tell you lysocell has a very good toxicity profile, also pretty good efficacy. And bispecific antibodies, I just want to highlight without the slides, unfortunately, the two which we use, now they are not FDA approved for this disease, but the two which are on the guidelines, there's only one on the guidelines actually, which is glofitamab, which is a bispecific antibody to CD20 and CD3. So it binds to B cells, CD20, T cells, CD3, and it can have efficacy in mantle cell lymphoma, although it does not appear to be curative. And if you look at the curves, over time, there's more and more patients who progress. We don't have long-term follow-up. The one combination therapy which is not yet published, we are a part of the study. The paper has been submitted to a good journal recently, so hopefully it will come out in the near future, and that's a combination of mosunetuzumab plus polatuzumab, and that has very good safety profile, excellent safety profile. I just presented the results of that study at ASH a few months ago in relapsed refractory DLBCL, but we also participated in a mantle cell cohort, which is about around 40 to 50 patients, and it again shows very good efficacy over there. And we don't have long-term follow-up, but very, very good safety profile with very low CRS, almost no ICANS, and all outpatient and easy to do and fixed duration therapy for 6 months. So with that, I'll end. And I'm happy to take questions for the next half an hour or so and take it from there.
Thank you very much, sir. I think we'll jump right into the questions if that's okay with you. Like I told you, we had collated the questions beforehand. If anybody has anything to ask, can be added to the chat box. Starting from frontline therapy, what is your approach to a young, fit patient with mantle cell today?
Yeah, so the first thing, that's a very good question. So for the first thing we do is check P53. And even if they are young, fit, and they're P53 mutated, we use Bowen. We use Bowen for all those patients, okay? And we look for MRD by an assay called clonoSEQ. And if they are MRD negative for 2 times, then we are good to stop the regimen in 2 years. So that's our standard approach. Now, if they're P53, P53 is wild type, then we look at a few other factors. We look at MIPI, we look at patient's age, you said young as well, but aggressive presentation, blastoid, pleomorphic, high Ki67. We still think that those patients would benefit from an anthracycline and high-dose Ara-C-based regimen. And there we use a triangle-like approach, but we do not use ibrutinib because, as I told you, ibrutinib has been withdrawn from the market for mantle cell lymphoma. So we use acalabrutinib or zanubrutinib in combination with R-CHOP. We usually, in our site, we usually don't use R-CHOP or DHAP. We find DHAP to be a little bit more toxic. So we use high-dose Ara-C instead, the Nordic regimen. So there's a lot of extrapolations which we are doing. We are getting rid of DHAP. We're getting rid of ibrutinib. We are substituting it with high dose Ara-C and Acala or thing. And we are checking for MRD, but we are not doing autologous transplant. So, if we always check for MRD. So I did not discuss a study because this talk was about BTK inhibitors, CAR-T, and bispecifics. But there's a very important study which we participated in, done by a good friend of mine, Tim Fensky, who, it was a cooperative group study, and this was EF4151. And this was also presented as a late-breaking abstract recently. And what it showed is that if patients are MRD negative, they were randomized to transplant or no transplant. And there was no transplant done for MRD negative, the outcomes were same as with transplant. So why add the toxicity with transplant for MRD negative patients? So for the young fit patient, if they're MRD negative, we are not doing transplant. I think the question always arises, if they're MRD positive, then should you do a transplant? I think transplant perhaps has a role in that group, but if we are not doing transplant and keeping them on BTK inhibitors at that point, then when they progress, the first thing they do then is get CAR T cell therapy. So that's sort of our approach for the young fit patient.
That I think answers a few of our subsequent questions as well. So is there any population where you would still recommend an autologous transplant? I'm guessing the answer is young, fit, MRD positive at the end of your chosen regimen.
Yeah.
Is that right?
Yeah. And then I will say this, I'm talking to a global audience here. So not everybody can afford a BTK inhibitor for a long time. So if you look at the old studies out of the Nordic studies, right? The Nordic regimen studies, we even have 15-year follow-up. So the best patient for a transplant is a low-risk patient. The low-risk patient who got 6 cycles of something, chemotherapy, and got into a CR, got a transplant, many of them are in a long-term remission 8 to 9 years out. So if you don't have access to BTK inhibitors, even though there's toxicity, the whole process of doing 6 cycles of chemo plus transplant could be over in 8 months. And then if you can have 8 years of remission, okay, and get BTK inhibitors only after that, then I think, it's still valid. It's just because it's so widely available and covered by insurance, it doesn't become an issue here. But it may not be the same in many places. So I think there is still a role when access to BTK inhibitors is low. But I really feel that we should avoid transplant and avoid these high dose things for patients with very aggressive disease and P53 mutation.
Got it. So on a BTK maintenance, a progression, either be it a young fit patient who got a triangle-like approach or an older patient who was in the 2-year span has progressed. I think you answered it. Your next step would be a CAR-T.
Yes. So we cannot do CAR-T without a BTK exposure. We usually need 2 lines of therapy. That's the approval. So if CAR-T is so expensive that we are not able to do it just without getting BTK. So of course, but somebody got combination chemo plus BTK, or they got Boven or something, and BTK has already happened, then we go straight to CAR-T. If not, we use BTKI. Let's say somebody does not get BTK in frontline and they just get BR. Okay, and then they progress. They get BTKI. They can get several years because you saw zanubrutinib gives 33 months median. Of course, there's a range for that. And then when they progress from that, then we think of CAR-T at that time. However, I will caution that there are some patients who we are thinking of CAR-T already when they are doing BTKI, because we know the response is not going to be great. CAR-T is not right off the shelf, right? It takes time to get financial clearance and then also to generate the cells and things like that. Last thing you want, something bad happens to the patient while you're thinking of CAR-T. So it is very important that for some patients, while they are on BTKI, we've already had the discussion that CAR-T may be coming, and we use it as a bridge to CAR-T.
Okay. I think that's the irony we see in many of these patients who progress very fast, where that's the patient where we want to access all the tools that we have, and that's exactly the patient who will not give us the time to, see the benefits of all of these tools. Right. So among the high risk factors that are well known in Mantle, which of them do you use to guide therapy? P53 clearly, but anything
P53
else?
clearly. And the other things which we use are, we do use Ki67, very simple marker, right? So we use 30 as a cutoff. And we also look at MIPI, right? So the MIPI score. And we also look at blastoid or pleomorphic histology. So those are the things which we really look at in terms of this thing. There's another thing we find very aggressive mantle cell is the ones who have leukemic component. I'm not talking about the mantle cell, which has only leukemic component and no lymph node, but those can be very indolent like CLL, but there are mantle cell lymphomas which have lots of lymphadenopathy. Ki67 is high, blastoid, and they also have a mantle cell leukemia ongoing along with that. Those really progress very fast. So we look at that as well. I
Right.
think there is somebody in the audience, Nikhil Kumar, who has a question. I
Yes,
see hand.
additional benefit of transplant in P53 mutated young fit patients.
Sorry. Okay, so that was the question. Is that the question? That
Yes, yes. Is there any
benefit of
added benefit to transplant in a patient who's P53 but still young and fit? To at least
so
bias time to relapse.
uh, I don't think so. I think these P53 patients just don't do well with chemotherapy. Uh, when you do autologous transplant, you're just giving high dose of chemotherapy, beam, and what benefit you're going to get from that other than toxicity for P53 mutated? I have yet to see a really good role for transplant in P53 mutated patients. I think when I see with a regimen like Boven without transplant giving over 80% PFS in 2 years with a nearly all oral regimen except the obinutuzumab, which given IV. But I don't know any other treatment which gives you that kind of thing. P53 patients often relapsing within 2 years of transplant. So.
In your treatment practice, where does venetoclax and lenalidomide fall?
Yeah, great question. So, venetoclax, I'll start with that. We participate in the Simpatico study, which was ibrutinib venetoclax versus ibrutinib placebo. That a number of patients, of course, that was a blinded study, so we don't know who got venetoclax, but there was a subarm of the study for P53 positive patients, similar to Boven, but just doing ibrutinib venetoclax. So all oral with no antibody, right? And I have patients on that 4 years out with P53 mutated, still in remission. And so I've certainly used that. I've used Boven, which is also venetoclax based. And so those are the two places where we use. Sometimes we have a patient who has exhausted things and is rapidly progressing, and we need to buy some time before CAR T is ready. And there we use venetoclax as a bridge. By itself, I think venetoclax is not very powerful, although it does have some activity. When in combination with BTKI, it seems to be a little bit better. So that's where I use venetoclax. Now, in terms of lenalidomide, so I'm a little surprised with lenalidomide whenever I've used it. So in my practice, I've used lenalidomide in frontline for some patients, and they've had very, very long remissions. But of course, I've very selected those patients. Low Ki67, very low risk disease, still an indication for treatment, because for a very low risk patient, if they have no reason for treatment, I usually just observe them. And I don't initiate treatment right away, because I think if you can observe them, I have at least one patient in my practice who is 6 years out from their diagnosis, an incidental diagnosis which was found when she was undergoing a mammogram for breast cancer screening. It turned out to be a lymph node, which was mantle cell lymphoma with a Ki67 of 5%. She's 6 years out in observation. It took me a lot of time to convince her that it should be observation is the right thing for her, and also a second opinion with another person. But I think every time she tells me, she's the most thankful that she's just sees me 2 times a year and doesn't have to do anything. and live her life. So along those lines, I feel like there are low-risk patients who can get Rituxan lenalidomide in frontline. There's a study out of Cornell University. GR1 is the first author. It was a New England Journal of Medicine paper, which has very, very long PFS in frontline patients. But I would never use it for a patient with high Ki-67, somebody with, high-risk disease, because there are people who are not going to want to do IV chemotherapy and all sorts of things. And back in the day, we did not use BTK inhibitors in frontline, so I have some patients who got. And in relapse refractory setting, I've also used R square, Rituxan plus lenalidomide. And lenalidomide is, I think, especially in India, much cheaper. And, when you combine it with rituximab, I think I have seen some patients with very, very durable response. I have a patient who failed BTKI and I've given her Rituxan lenalidomide. She's 5 years out. I just saw her. 5 years out, she had a horrible toxicity from lenalidomide, unfortunately, and she had lots of infections, but she overcome all of that, and she's been off treatment now for more than 4 years, and she is doing great without any thing. So there are some odd patients. I just don't know how to select them, honestly, in relapse setting, who is responding and who won't. But we do use it, when patients are either not able to get CAR T, or if they want all oral option with some rituximab. So there is some role for lenalidomide, surely, in this disease.
Right. So I think where we tend to find it challenging is we tend to use when in situations where we are almost desperate to buy time. Either we are procuring a bispecific in the meantime, or we have done the apheresis for a CAR T, and that's probably not the right time to be using the Ven, because they are already cytopenic. Most of them have marrow involvement by this time, and tolerating the Ven becomes difficult. So probably moving it up the line of treatment would be a more sane way to use it. Some questions on bispecifics. Do you think bispecific antibodies offer a meaningful advantage in P53 mutated patients?
We don't have the data for that. So, we are awaiting data specifically like that, the number of patients. So first of all, bispecific is not approved, right? For mantle cell, at least in the US, it's not approved. So when something is not approved, glofitamab is on the NCCN guidelines, so insurance can cover for it, but it's a challenge to use when it's not approved. Secondly, we are a CAR T site, so we've used a lot of bispecifics as well, because CRS with glofitamab can be significant, and especially in high tumor burden patients. So that's where I discussed with Mohsen Pola, because mosunetuzumab has a much lower CRS rate, and also when you do it with polatuzumab, which we have never used in mantle cell otherwise. So frontline doesn't have polatuzumab, right? Unlike DLBCL, where polar CHP has become quite a popular frontline regimen. So now we are using two agents which have never been seen by the patient. Glofitamab needs inpatient hospitalization for 1 day during the ramp up. Mohsen Pola does not have any of that. And side effect profile is low and efficacy is high. So I think in that situation, I see Mohsen Pola as a future. Of course, it's not been published. So, it's just, and I'm not able to disclose the response rates because the paper has been just submitted, but for the mantle cell cohort. But I think, it has, you'll see that it has good efficacy and low toxicity. So I think perhaps in a subsequent program, I can discuss bispecifics and CARs more in detail. But I think it's promising. It has to be relatively easy on the site as well. If it leads to hospitalization, lots of tocilizumab use, and lots of other things, and ICANS is not very common, but CRS can be a problem with some of these. Then, and of course, cost. I do think that for bispecifics, it's important to think of fixed duration regimens. Bispecifics are very expensive as well, and if you have indefinite therapy, that becomes very expensive. Even with Mohsen Pola, I don't have long-term data. Time will tell whether it's going to be more buying some time versus curative in some patients, at least in mantle cell. A different story in DLBCL.
Do you see any situation where you'd use a bispecific before a CAR T?
No, first of all, it's not approved, not in mantle cell. It's not approved. CAR T is approved, at least for us. So for us to use something which is not approved earlier than an approved therapy, that's going to be difficult. Second, I see with CAR T cell therapy, some patients who are in long-term remission. It's possible with bispecific that'll be the case, but there hasn't been that much time from the glofitamab study or the Mosun Pola study for me to be telling that to a patient. So I don't even think it's probably right when we have 5-year data for CAR T, but only a few, shorter follow-up with bispecific in mantle cell specifically. Again, different story in DLBCL, but not mantle cell.
I think we'll wrap up with two questions, sir. First
Yeah.
is, in a setting where I think from the entire understanding of what you said, the disease biology significantly changes once the patient becomes BTK exposed. Is that correct? And if that is the case, does it make sense to save it for a relapse in a setting like India, where I would not be wrong in saying that for most of us, the go-to option is BR?
Yeah.
And yes,
And
Acal and Canu are available easily. Should we be
yeah.
adding it upfront? Should we be saving it for a relapse?
That is why specifically I spent 7-8 slides in that sequencing discussion. So you said that BR is the most commonly used regimen in mantle cell lymphoma. I can tell you in the US, BR is the most commonly used regimen for mantle cell lymphoma. Now, maybe because ECHO just got approved, people have started using acalabrutinib with BR just because they can. But I just wanted to make the argument for sequential use, especially when cost is an issue and toxicity is an issue. Even if cost is not an issue, think about how many years a patient will be on BR plus acala, right? If we use acalabrutinib in combination with BR, versus how many years they'll be on acala if it's used sequentially with similar or better outcome, right? We don't know whether it's better, but there is no improvement in overall survival. The study included crossover, which means that patients were able to get acalabrutinib at the time of relapse. And in that study, you're seeing no difference in overall survival, which means that if you use it sequentially, which is for the standard arm, and if you use it concurrently, which is for the experimental arm, the overall survival is the same. So what you want to look in these kind of studies is what is going to be the PFS2, second PFS, and if that matters, if that basically adds up to the experimental arm, then then it's nullified. So I do want to make the case for sequential therapy, but that's why in the slides I highlighted that there are some patients where you don't want to do sequential therapy, right? Because in a P53 mutated, you don't want to give them something which is not going to work. You might as well give them the best one up front, in combination with venetoclax, and just see if that gives the best outcome. It's also much well
You
tolerated
pick the
than
patients where
you pick the
you
patient.
apply
It's not one size fits all in mantle cell. Rare disease, but there's so many things to consider when you're trying to make that decision. And even if BR, and you can still use BR, and that's why I included the cytarabine slides. You can still use BR and add high dose cytarabine, that's BRCR, and add acala or not add acala. But there also, I showed you that in most of the patients, just BR plus acalabrutinib was good enough. You didn't have to do cytarabine for the toxicity issue. So
Before my final question, two questions from Dr. Nikhil.
yeah,
Definite versus indefinite BTK, I think maintenance based on MRD. Can that be decided after a BR-like approach?
sorry, well, can you repeat that question again?
Can you
Indefinite.
use MRD to decide if you're going to give a finite duration of BTK maintenance versus an
Yeah.
continuous
Yeah,
BTK?
for sure. So, if you, when you look back at the Bowen study, right? If MRD was negative 2 times, right? If MRD was negative 2 times, then in Bowen, BTK inhibitor and venetoclax both were stopped, right? So, so the trial was designed with that intention. And if MRD is not achieved, then continue. So, and then even when you look at the Traverse study, it was actually randomized based on MRD. So that's the Acala plus venetoclax study, right? So in that study, if MRD is negative, now you have a randomization based on that, whether you should do just observation, right? Versus if you should continue the Acala. So that when that study results, we will know what will happen if you stop Acala at MRD negative versus you continue Acala at MRD negative and tell us. But in my mind, if someone has achieved a MRD negative and we confirm that MRD negativity, then I think you can stop and re-challenge if they become, if they have progressive disease later, because now you're not refractory to BTKI. You stopped it on choice, right? Because you achieved an endpoint. And so you can re-challenge and might be able to get another long remission. But in between, you give the patient treatment-free interval, which is, I think, from a patient standpoint, that's the most important thing for patients, that if they can get some break from these treatments, then they can get their quality of life back. While they are achieved a very deep remission, why not give them a break, right? And it lowers cost, which is very important as well.
Another question, role of ctDNA as an adjunct to PET in Mantle?
Yeah, that's very important. So, I think that is, you talked about molecular diagnostics, and that is a very important thing which has come through. There have been increasing number of studies where MRD negativity is an endpoint, and what you do with that MRD negativity is important. As an adjunct to PET, hopefully one day, not even it's more expensive to do, honestly, a PET scan than to do PCR or NGS. At the end of the day, one day, hopefully we'll get like a blood test, which can tell you if you need more treatment or not, and not have to do scan after scan. But we are not there yet. We do clonoSEQ. I don't know if what clonoSEQ is a
We do
MRD.
have access to clonoSEQ-like assays here.
Right. Perfect. So NGS-based multiplex PCR. So I think those, but then there are newer ones which are coming out. There is one which is called phase-seq, and that we'll see how that goes. Mostly done on clinical trials. But I presented many trials today which were all MRD based. The Bowen study, Traverse study, the EA4181. And I talked about EA4151, which is the MRD-based transplant versus no transplant. So making big decisions, like a patient would get transplant versus no transplant based on MRD. So I think MRD is becoming important in that, a validated tool. And of course, we need 5-year data for post-MRD randomization to say that did we do the right thing or not by making these decisions. But I think
more
it's
information in the future.
more and more studies are including MRD as an endpoint.
So the final question, what do you see as a cured patient in mantle cell, and which of the tools that you have today you think offers the best chance of a cure?
That's a great question. So I'll define cure as two things, right? One is someone is truly cured, right? Where they basically have no evidence of mantle cell and they likely never have a recurrence of mantle cell. And I have a few of those patients. And then there is functional cure, where somebody who is got no evidence of detectable mantle cell perhaps, or maybe they have MRD positivity, but you don't have any evidence of disease otherwise. And maybe they are older and they have an expected lifespan, and mantle cell will be not the reason why they pass away, right? Either mantle cell or the treatment for mantle cell would not be reason that they would pass away from natural causes, right? So I think both are important. Why? Because mantle cell is technically, if you look at the age incidence, it's a disease of elderly, and so when you reach that age group, if you can make somebody, even with BR, if you can get somebody in a long-term remission with BR and they pass away from a natural cause, in my opinion, they were functionally cured. So I think there are a lot more functionally cured patients than truly cured. Perhaps if that person lived for 110 years, maybe the mantle cell would have come back, but that's not the case. So in terms of true cure, the ones which I have in my practice who I can tell them that I think you're cured and will never come back are the ones where we have done allogenic transplant on. So there are patients I have who have received allogenic transplant and they are in long-term remission more than 5 years out. And they had disease which was recurring every year or every 6 months, failed autologous transplant, failed this, failed that, failed clinical trials, and now for 5 years, no treatment, and they are in remission. I think that person is likely cured. I have a few patients who are like that from CAR-T as well, and that's not a very large number, and I don't want to suggest that CAR-T is essentially curative in mantle cell. We have that data in DLBCL, but not yet in mantle cell. But I can say that a subset of patients are in long-term remission. And I think if that persists for a longer time, with allotransplant, we have decades of data. With CAR-T, we don't have that much decades of data. We have 5 year up to 5 years. So I think there's a potential that some patients will be, at least in my practice, I have a few patients who are in long-term remission after CAR-T. And before that, they were relapsing every 6 months to 8 months. So I think it's perhaps curative, but I'm a little hesitant to say that. So those two are, in my mind right now, curative. But I think some patients who are even on long-term BTK inhibitor and they're having a nice long response, or with just regular treatment, if they're older and they're doing well, they are perhaps functionally cured as long as it doesn't impact their lifespan. So I think those are the ways we should look at in terms of cure.
Thank you. Thank you so much, sir. Thank you for taking time to make the slides and educate us today. It was a pleasure having you here, sir.
Okay, thank you so much for the invitation, and sorry for the break in between for me trying to search more slides, which we didn't have time for anyway. Okay, great. Have a good weekend.
Thank you. Thank you, sir.
Bye.